And welcome to the University of Melbourne Centre for Cancer Research webinar today. I would like to acknowledge the Wurundjeri people of the Kulin Nation, the traditional custodians of the land on which we are based, and pay our respects to their elders past, present and emerging. Welcome everyone. My name is Michelle King and I'm the Program Manager for Professor John Emery's Cancer in Primary Care Research Group, which conducts research in primary care and also includes PC4, the Primary Care Collaborative Cancer Clinical Trials Group. Today we have two speakers for you, and first up is NAPIN, who also goes by PINN, and she will be exploring symptoms and help-seeking triggers in upper gastrointestinal cancer patients. PINN is a research assistant with the Cancer in Primary Care team led by Professor John Emery. She has a background in genetics with a passion for creating impactful change in healthcare by translating novel research into real-world use. Next year, she will be attending the University of Cambridge to further her studies in a Master of Therapeutic Sciences. Questions can be asked by using the Q&A function throughout the seminar, and these will be addressed at the end of PINN's presentation. Thank you, PINN. Go ahead.
Thank you, Michelle. So today I will be talking about the symptom UGI study, which is a mixed method study exploring factors impacting symptom appraisal and help seeking in esophagogastric and pancreatic cancer patients and its impact on time to diagnoses. The study was completed in collaboration with Monash University, and as a mixed method study, our qualitative data was supported by quantitative data. So why did we do this study? Pancreatic cancer has the highest mortality rate among all cancer types and a 5-year survival rate of 8%. In esophagogastric cancer, esophageal cancer has a 5-year survival rate of 16%, and gastric cancer has a 5-year survival rate of 27%. The numbers on the previous slide reflect presentation of these cancers at a relatively advanced stage at diagnosis. International evidence suggests that time to presentation and time to diagnoses for these cancers are longer than other common cancers. Patients may be symptomatic for many months before presentation, and even after presentation, 61% of pancreatic cancer patients and 43% of esophagogastric cancer patients visited their GP about their symptoms at least 3 times before a referral. In Australia, there is limited evidence on the onset and development of pancreatic and esophagogastric cancer symptoms and how patients appraise their symptoms and decide to seek help. Therefore, we aim to examine patient, tumour and symptom factors associated with longer time to presentation and time to diagnoses in pancreatic and esophagogastric cancers. We looked at patient interval, which is the time from the date of first symptom onset to the date of the first healthcare consultation. We also looked at the diagnostic interval, which is the time from the date of the first healthcare consultation to the date of diagnosis. Together, the patient interval and the diagnostic interval forms the total diagnostic interval. Our secondary aim was to assess the feasibility of recruiting patients through Monash's Upper Gastrointestinal Cancer Registry. This is a clinical registry which collects information about the diagnosis, treatment and outcomes of individuals with an upper GI cancer from participating UGICR sites, which also includes 65 hospitals. The UGICR collects information from hospital records, private clinician medical records, telephone or email surveys, and from the Victorian Cancer Registry. They also notify the UGICR about potentially eligible patients for the symptom UGI study. So for our study, researchers from Monash identified eligible patients from the UGICR. They then invited them into the study via mail. They sent the patients an invitation letter, as well as a symptom UGI questionnaire, which asks patients about their symptoms, the absence or presence of symptoms, how long they had those symptoms for, and if they told their GP about it. We also asked for their consent to call them for a phone interview and to also contact their GP about their symptoms 12 months preceding diagnosis. If we received consent, Then researchers from the University of Melbourne would contact the participants to do a phone interview and also contacted their GP by mail. The interview transcripts were analysed using in vivo, and finally, data from the UGICR, the questionnaire, the interviews, and the GP records were analysed. From 489 screened patients, we had 90 eligible patients. This was due to the fact that one of our eligibility criteria meant that our patients had to be diagnosed within the past 6 months. However, by the time that the UGICR were notified by the participating site about potentially eligible patients, the patients had already been diagnosed more than 6 months, which deemed them ineligible. From the 90 eligible participants, 27 responded to our mail invitation and 13 agreed to our phone interview. From the 27, we had a median age of 72. We had a mix of male and female. 7 had esophagogastric cancer patients. 20 were pancreatic cancer patients. 8 presented with early stage cancer and 4 with late stage cancer. 19 lived in rural metro areas, 8 in rural areas, 3 went to a private hospital, and 24 went to a public hospital. In the 13 which agreed to a phone interview, the median age was 68. We had a mix of male and female, 3 with esophagogastric cancer, and 10 with pancreatic cancer. In both groups, we had a smaller number of esophagogastric cancer. We had 3 presenting with early stage disease and 3 with late stage disease. In both groups, we did not have all cancer staging information, as some were missing or unknown. We had 8 who lived in metro areas, 5 in rural areas, 1 went to a private hospital, and 12 went to a public hospital. Due to a small sample size, we were limited in identifying patterns and trends, as well as making significant statistical comparisons. From our data, we found that in pancreatic cancer, the most common symptoms were pain in the upper part of the stomach and jaundice. And in esophagogastric cancer, the most common symptoms were regurgitation and unexplained weight loss. However, all symptoms were reported at least once. In the patient interval here, you can see that pancreatic cancer patients had a shorter patient interval than esophagogastric cancer patients. This is seen also in the diagnostic interval and in the total diagnostic interval. While recognizing the small number of participants, the subgroup who reported jaundice, which tended to be pancreatic cancer patients, had a shorter patient interval and diagnostic interval, and jaundice is also associated with more urgent and immediate referrals. From our interviews, we found that patients had a lack of cancer symptom awareness. On the left here, this woman said, "I think with the stomach cancer, well, you know, what are the symptoms? Like with breast cancer, if there's a lump or tenderness or tingling, you know, you better go and have that checked." So in this case, she compared her symptoms with the symptoms of a more common cancer. On the top right here, this woman said, "I think had I been more aware of the initial symptoms of pancreatic cancer, I might have put together the fatigue and weight loss that I was experiencing. I might have just thought, even though I was attributing those to other things, it might have occurred to me to mention it to the doctor." We also found that lack of cancer symptom awareness led patients to normalize, dismiss, and misattribute their symptoms. This man here on the left said, "I've always had a bad back. I've got 3 prolapsed discs, so that's a hard one to distinguish between." So in his case, he misattributed his cancer symptoms to his prolapsed discs. On the right here, this man said, "At the time, I was that busy with my wife and I didn't take much notice of it and that sort of thing." So in his case, personal matters led him to dismiss his symptoms. We also had patients who self-managed their symptoms as they believed they were minor enough to do so. This woman on the left here said, "I managed what I ate and when I ate and how I ate it, so that I could reduce the symptoms. I would eat very lightly." This man here on the bottom right said, "You can't start messing around with the amount of insulin you have, but I had to do that to try to get the blood sugar readings somewhere near reasonable." So this man was a diabetic and he tried to manage his insulin intake in order to manage his symptoms. We found that patients who did not self-manage their symptoms had a shorter patient and diagnostic interval in comparison to patients who did self-manage their symptoms. Others also had a role in symptom appraisal and help seeking. We asked this man here on the left here if he's spoke to his family about his symptoms. We asked him, did he encourage you to seek medical advice? And he said, no, we're not like that. So in his case, talking to family did not prompt help-seeking behavior. On the right here, this man said, my wife is going through cancer at the same time. I didn't know I had it. One of the public care nurses told me to see a doctor because I was going yellow, and she didn't like the look of it. She made sure I went and saw the doctor that day or the next day. Jaundice was often noticed by other people, and it was also one of the most common symptoms among patients with shorter patient and diagnostic intervals. The decision to seek help was impacted by multiple factors. On the left here, we have delays in help seeking. This man said, probably if Anna hadn't been sick, I might have done something and gone to see the doctors a bit earlier. So in his case, personal matters delayed his help seeking. On the bottom left here, this woman said, it happened on the Sunday and I went to ring the doctor on the Monday and I couldn't get in until the Tuesday. So in her case, she had difficulty accessing. On the right here, we have triggers for help seeking. This woman on the right here said, I had this pain in the middle of the night, sort of all around my stomach, and I called the ambulance and they took me to the hospital. So in her case, a sudden onset of pain prompted help seeking. In the bottom right here, this man said, the doctor was testing me for something completely different and something didn't look right. So he ordered an ultrasound and that's where they picked up lesions in the liver. It was a totally accidental find. So in his case, he went to see the doctor for something else and they found the cancer incidentally. We also explored impact of family history of cancer on help-seeking behavior. Existing literature found that patients with a family history of cancer tended to be more concerned about their own cancer risk, which then affected their decision to seek help. However, our findings found that participants seemed unconcerned with the family history of cancer and it did not affect their decision to seek help. This man here on the left said, well, not that I've discussed the details, but I had an older sister who did die of pancreatic cancer. This woman on the right here said, my twin brother died 3 years ago. He was rushed off to the Dandenong hospital and they discovered a tumor in his bowel. Our destiny is, I believe, it's mapped out for us and we have no control over any of that. So in her case, she framed cancer as something out of her control and that there was nothing she could do about it. Once help was sought, there were factors impacting their time to diagnosis. This woman on the left here said, I didn't mention the weight loss or the fatigue because I didn't associate them with the abdominal symptoms. So despite seeking help, a lack of cancer symptom awareness meant that she omitted telling her GP about some of her symptoms. On the right here, this man said, it actually took 3 or 4 months for them to actually organize to stick the camera down my throat and have a look. So in his case, he had difficulty in accessing specialist services due to organizational delays, which lengthened his time to diagnosis. Furthermore, we also explored the primary care interval, which is the time from the date of first healthcare practitioner consultation to the date of referral. On the left here, this man said, he didn't sort of think much about it. Yeah, I didn't know whether it was to do with something with asthma or what, but nothing was sort of done anymore about that. So in his case, his GP misattributed his cancer symptoms to his asthma. On the right here, this woman said, I went to my doctor and he'd always seen me like a star patient in terms of, oh, Sam's no worries, she's out there, she's fit, she's always been. So in her case, her doctor also dismissed her symptoms. We had an overall primary care interval of 6 days. However, when the doctors dismissed or misattributed the patient's symptoms, the primary care interval increased to 30.5 days. So in conclusion, our findings add to the literature surrounding the subtle and insidious onset of esophagogastric and pancreatic cancer symptoms. We've highlighted factors influencing symptom appraisal and help seeking, including lack of patient awareness of cancer symptoms. In the future studies could address this by targeted symptom awareness campaigns. We also assessed the feasibility of recruiting patients through the UGICR. And despite our small sample size, we successfully recruited newly diagnosed pancreatic and esophagogastric patients from the UGICR. In the future studies could focus on esophageal, gastric, and pancreatic cancer patients in separate, larger cohorts. However, our challenge still remains in timely access in recruiting patients from multiple hospitals with less common cancers soon after diagnosis. I'd like to thank Professor John Emery and Shakira from the University of Melbourne for all their help and support, and also the Monash team, Professor John Zalkberg, TJ, and Jenny Holland for all their help and guidance. Thank you. Does anyone have any questions?
Thanks, Pen. That was great. Yeah, if people want to put their questions in the Q&A for Pen. I've just got one question, Pen. Just in regards to the mix of metro and rural patients that you had, was there any difference, or did you notice any difference between when they seeked medical advice? Did they take any longer? Did any group take any longer in seeking medical advice?
Yeah, we haven't investigated that, and that was mainly because we had such a small group of patients. So we tried not to extrapolate our data too much, but I think that's an interesting point that we could probably have a look at.
Yep. We haven't got any questions coming up, so if you want to put your questions in there, give a couple of more seconds. No. Okay, well, thanks, Pen. We might, we do have one. They're coming in now, Pen. Pen, how do you think this study will affect future practice?
So in future practice, I think especially with the targeted symptom awareness campaigns, if GPs are more aware of the symptoms of these cancers, which are quite subtle, and so they might be able to identify these symptoms faster, and especially if the patients themselves are more aware, then they might be able to be diagnosed a lot faster as well.
Great. Okay, so another question here. Hi, thank you for your talk. One note is to say that unfortunately the UGI cancers have vague non-specific symptoms, so even if earlier reporting, it may not lead to earlier investigation, as these are non-specific symptoms are often thought of as reflux, so managed conservatively, and hence the delay. So how do you propose symptoms campaigns changing this you have that you have as the data says otherwise?
Yeah. So we had a lot of patients who actually reported indigestion, reflux, and a lot of the times they just thought it was a normal thing to have in life, and because of that they wouldn't go see their GP. And I think in terms of the symptom campaign, it might be helpful to list all the symptoms, because a lot of the times patients have concurrent symptoms that occur together. So for example, if the patients knew that, I've got indigestion and reflux, but I also have difficulty swallowing or unexplained weight loss, then they might be able to go to their GPs a bit earlier. Yeah, I think that's how we'd go about it.
Great, thank you, Pen.